Thanks to be here.
Thanks to Ronaldo.
I ask for the indulgence because I will discover my topic. I will speak about the non-infection after UBE surgery, maybe the most difficult topic today and the most interesting for you. As you know, we work together with Guillaume and other surgeons who are here with the spinal research community, and we try to share all the data together with the same software. Okay. We share together some data with Montpellier, Bordeaux, and Marseille. And I think Philippe Cam, my associate, is here today, not like yesterday morning. And we have also a rheumatologist and a readaptative doctor, Dr. Palazzo, a friend of Guillaume, who will work with us in our institute. Very proud to have you in our team. Very difficult abstract is to evaluate the rate of the infection. Usually we can describe an incidence between 0.2% and around 15% in the literature. Everybody knows the risk factors for this kind of infection, and what is the game changer for endoscopy, even in uniportal. I don't like war. We have a lot of continuous saline irrigation, maybe more in UB. And there is a permanent lavage during the surgery, and the question was, do we have lower infection rate? It was a retrospective multi-standard cohort study with 4 French centers. We included during 2 years, around 2 years, and we included more than 1,600 surgeons. For all these surgeries, like as usual, same levels, same kind of surgery, more than half of the surgeries was discectomies and decompression for stenosis. The average for the age was about 60 years old, very young man, like Mr. Pestonji. He's not here. Oh, sorry, it was like Mr. Young. We invite you at the next meeting. For the risk factors, smokers, diabetes, and for more than 50% of the centers, no antibiotic prophylaxis. Maybe one of a good point for us to discuss after, if you have any question, but I don't know. We have no infection reported in our study, and independently of the use of antibiotic prophylaxis. Very difficult result to comment. No infection, no variability, and the clinical result at 3 months, and just clinical and conclusion. But it's not true, because 2 weeks ago, a friend of mine and associate in Marseille told me because he had an infection. And I have to be honest with you. But now we had an infection, but during this study we had 0 infection, and we think that we won't use antibiotics during the surgeries, I think, and for the next protocol. Thanks.
Just a question, Joseph. Your colleague uses antibiotics or no?
No.
Oh, okay. Does anybody has a question?
I don't know what is the habit in the room of the antibiotic for you. Do you use antibiotics?
Yes, in every patient.
In every patient?
Yes.
And the other guys said the same thing? Because in France, the anesthesiologists work a lot on that, and they push on us to
Don't use
stop
it.
the antibiotics. And I think at the end we see that there is no...
Yes, we use it, but we don't know if it's worth it. After this study, I don't know.
It's already done. I was in the expert in the anesthesiologic new guidelines, and in France you don't have to use antibiotic for procedure without implants. Without for UBE and upon in our center we choose to keep the antibiotic just for open surgery, but for each endoscopic surgery we stopped it. But the recommendation is even if you don't put some instruments, you don't have to put some antibiotics. This is the recommendation. The French recommendation.
Induction, Anesthesiology Society.
Yeah. Do you give antibiotics at induction? No, not anymore.
Not even at induction.
No.
A single dose.
Yeah.
Maybe a factor that we should keep in mind. Probably you are experienced surgeons. What about new surgeons that probably will have longer operating times? Maybe you should think about that.
More saline irrigation.
Yes.
Yes, correct.
The more longer you are.
It's an interesting remark because when I started 1 year ago, I prescribed systematically antibiotics in the beginning of the surgery just because I didn't want to have infection in that kind of the beginning in a private practice, you know. So
Better be safe than sorry.
I'm self-confident, so maybe I can stop antibiotics if you follow the recommendation.
The activities may be useful. Maybe you will have infection, I don't know, but you won't have problem in case of malpractice claim.
Yeah,
Because the
that's
guidelines
the
published, you don't have to do it. That's what the requirements in your private practice.
Keep your patients safe. That's my remark. Because you never know what will happen, especially in the early phases. No matter how much time you take your time. Don't rush an operation. Take your time. Give antibiotics. And then you will rest.
Literature don't say that.
I do.
If you do, okay, you
I do.
But if you publish some guidelines, you know that you have to do a review and you have to publish what is up to date in literature. Actually, there is no argument in the published literature, high-level studies, to promote antibiotic in cases of decompression, open, miss, or endoscopy if you don't put implants. So that's why that's the rule of the published guideline. If you want to do it, do it. But it's your decision as an expert. But if you follow the guidelines, and I'm sure in your country like in France, it's the same thing. If you have a claim, malpractice claim, the expert will examine what you have done, you and the anesthesiologist, and what are the guidelines. And at the end, if your patient, I don't know, allergic to your antibiotics because you choose to put antibiotic prophylaxis to a patient, he do, I don't know, a rash or something very important, penicillin allergy, you will be guilty to decide by yourself to give antibiotics to the patient.
There's a checklist anyway. You should ask whether you have allergies or not before you administer an antibiotic. Okay. If you don't do that,
But it's a question of philosophy. You can, as a surgeon, decide or not to follow the guidelines. Guidelines are not the truth. They are just the view of what is up to date today in terms of evidence-based medicine, which is not the real. Well, they are the rules of the guidelines.
But Bertrand, what is about Europe? Because you said in France.
I can't speak for France, but
Okay, it's
the literature is not in France. No, the literature, of course, it was not the literature for France.
okay, but it's not in guidelines for Europe or whatever. We don't know.
There are no international guidelines, but we have to follow the guidelines of our society.
find surgery, you normally have guidelines to use antibiotics and the type of antibiotics as hepatoplasty, as general surgery. So we have guidelines, outdated guidelines, but they still say that. So
we
have to
decided
adapt.
to do this 2 years ago because it was the last guidelines was since no change since 15 years. So we decided to change and to dive into the literature.
A quick question, because if you are new, for example, and there is always perhaps the risk of having to convert to open surgery, maybe it would be good to give antibiotics right before, because you need to give them the first dose half an hour before opening. Do you have? You don't. Okay. So the first dose is not.
It's a decompression anyway, so you don't have to do antibiotics. Because even if you convert to only a decompression, not a fusion.
Yes, but open surgery, you would need to give antibiotics, right? No. Ah, okay.
France at least.
Okay.
Except if it's in recurrence or obese or some risk patient.
Yeah.
Most of patients.
Okay. In Sweden, where I work, we've had some infections with open surgery, whether it be microdiscectomy or decompression, so we usually give.
You don't have to convert. Never.
Yeah, so let's move.